Acute stress reactions and post-traumatic stress disorder. These conditions are produced by exceptionally stressful and life-threatening events. Acute stress reactions tend to develop rapidly and are short-lived. Post-traumatic stress disorder, PTSD, runs a more protracted course. Adjustment disorders are provoked by major adverse life events which are less intense and immediately traumatic than those which cause acute stress reactions and PTSD. The characteristics of acute stress disorders, PTSD and adjustment disorder are shown in Table 24. Acute stress reaction. Etiology and psychopathology. By definition, the necessary and immediate causative factor for this condition is an exceptionally stressful life event. Some individuals might be more prone to developing this disorder than others, and the reaction is more likely to occur in the elderly or if the person is physically exhausted. A previous history of psychiatric disorder also increases vulnerability. Epidemiology. The prevalence of acute stress reactions depends on the severity of the trauma that instigates them and the degree of exposure to it. Thus, the incidence of acute stress reactions among the survivors of an industrial explosion and fire at a Norwegian paint factory was directly proportionate to the individual's proximity to the center of the explosion and conflagration. On the other hand, 1/5 of police officers who had to handle bodies after an airplane crash developed a severe stress reaction although there was no direct personal threat. Clinical presentation and prognosis. This is a short-lived but severe disorder caused by an overwhelming, psychologically traumatic experience. The condition generally subsides within hours or days. Examples of such exceptional stressors include rape, assault, a life-threatening accident, a transport disaster, a domestic fire or multiple bereavements. The symptoms of an acute stress reaction develop rapidly and tend to vary in character and fluctuate in intensity during the first few hours after exposure to the precipitating event. Clinical presentation of acute stress disorder. Psychological. Feeling numb and detached, or dazed and disorientated. Disbelief that the precipitating event has occurred. Agitation and overactivity. Fear, dejection, irritability, and anger. Hypervigilance and enhanced startle response. Action replays of the incident and intrusive memories and dreams. Withdrawal and avoidance of reminders of the incident. Irrational guilt about surviving or failing to help others. Poor concentration. Loss of interest. Physical. Sweating. Shakiness. Rapid heartbeat. Fatigue. Insomnia. Nightmares. Loss of appetite. Nausea and diarrhea. The condition tends to resolve within a matter of days, but some survivors will go on to develop PTSD. Some victims might withdraw into a dissociative stupor or run away from the scene in a state of fugue. Treatment. If there is persistent denial that the event has occurred, the survivor should be cautiously prompted to recall the facts. A very short course of a benzodiazepine tranquilizer and/or hypnotic is indicated for severe agitation or insomnia. Post-traumatic stress disorder. Etiology and psychopathology. The individual is involved in or witnesses an event that is an extreme threat to themselves or others, such as a large-scale disaster, e.g. Hillsborough Football Stadium in 1989, the King's Cross Station fire, the Paddington rail crash or the July 7 bombings. A personal trauma such as rape, torture or assault. The psychological impact of the traumatic event is known to be more severe when the stressor is man-made rather than an act of God, such as a natural disaster. Vulnerability factors include a previous history or family history of psychiatric disorder. Children and the elderly have an increased risk of developing PTSD. In some cases physical injury might also increase the risk, but in other victims, e.g. civilians exposed to bomb outrages in Northern Ireland, survivor guilt was more frequently encountered in those who were physically unscathed. Epidemiology. The incidence of PTSD is proportionate to the intensity of the psychological trauma. For example, 70% of rape victims are found to have PTSD at 9-month follow-up. In general, about 25% of individuals exposed to exceptionally traumatic events develop full-blown PTSD, but the frequency can vary. Thus, about 16% of London Underground train drivers who witnessed a train striking a person on the track developed PTSD, while careful psychological preparation of the police officers who handled the bodies of the Piper Alpha oil rig victims prevented the occurrence of any post-traumatic illness. Clinical presentation. PTSD is a protracted psychological and behavioral reaction to an exceptionally threatening or catastrophic event that immediately induces intense fear, horror, and/or helplessness. The onset can be delayed for some years, and it might only emerge when the victim is exposed to a new extreme stressor. The symptoms of PTSD are recurrent, distressing and intrusive images of the event, dreams and nightmares which do not necessarily depict the incident, avoidance of reminders of the trauma, detachment and numbness, hyperarousal, anxiety, insomnia, poor concentration, enhanced startle response and irritability. The patient may also experience survivor guilt, defined as the irrational sense that one's life was purchased at the cost of another's. Phobic avoidance of any situation that resembles the original traumatic event. Depression. Generalized anxiety disorder. Substance misuse. Some patients become aggressive while others, surprisingly, behave recklessly. Treatment. Psychological, direct exposure therapy, anxiety management training and cognitive therapy all improve PTSD by 20 to 80%. Pharmacological, both serotonergic tricyclic antidepressants, e.g. clomipramine, and selective serotonin reuptake inhibitor antidepressants may help to suppress flashbacks and nightmares as well as reducing the frequency of panic attacks, in addition to their specific antidepressant effect. Prognosis. This has not yet been clearly established. About 1/4 of rescuers involved in an oil rig disaster were found to have PTSD almost 12 months after the event. There was still a high rate of PTSD in severely abused former prisoners of war 50 years after their release. Prevalence rates for PTSD can range from about 30% among Australian firefighters to over 80% among Cambodian refugees. Prevention. Remind survivors that it is perfectly normal to react emotionally to an abnormal event. Gently encourage survivors to talk about the traumatic event rather than sweep it under the carpet. Go at their own pace and without intrusive pressure. Advise them to avoid using alcohol to suppress symptoms, because it can delay resolution. Encourage them to keep up their usual routine activities. There have been no large-scale, controlled and prospective studies of the efficacy of early crisis intervention.